4, 3, 2, 1. We are live now.
Good evening. I'm Dr. B.M. Zishan Hamid, Associate Professor in Department of Urology, KMC Manipal. Greetings from Manipal University. We are here to witness the second round of residents debate, which is Crossfires in Endourology, which is organized by Endourology Subspecialty Section under the aegis of USI and Indian School of Urology. In today's program, we'll have opening remarks by Dr. Rajiv TP, who is the Honorary Secretary of USI, followed by presidential address by Dr. Anant Kumar, the President of USI. Then we have Dr. Rajiv Sood, who will give his address. He is the Chairman of ISU, and a brief overview by Dr. Arvind Ganpule, who is the convener of Endourology Subspecialty Section. Then we'll be having three debates who are the winners of previous round one, and they all will speak for 8 minutes, followed by 2 minutes of rebuttal. We have 6 debaters: Dr. Manoj Kumar Singh, who will speak on ESWL, versus Dr. Rohit Ranjan on PCNL for pediatric renal calculus. Then we have Dr. Abhi Shegde, who will speak on prone PCNL, versus supine PCNL by Dr. Manhar Singh Rajput for a pelvic stone. Then following which, we'll have the third debate where we'll have a calculus in calycial diverticulum, which will be debated by Aditya Gupta, who will speak on RIRS versus Sepuria Raviteja on PCNL. Following which, the results will be tabulated and scored by various eminent faculties from Urology Society of India, who will be kept unknown, and the results will be announced. Then we have our last session, which is talk by various famous innovators and well-known urologists, senior urologists from Urology Society of India. We have Dr. Desai sir, Mahesh Desai, Dr. Janak Desai, and Dr. Kaushik Shah, who will be giving a talk on 5 minutes each. The whole session will be moderated by myself and Dr. Karthikeyan, who is my colleague from Frontline Hospital, Trichy. To begin with, now we start our opening remarks by various dignitaries. Thank you.
Good evening, everyone. President, Urological Society of India, Professor Anand Kumar, Chairman, Indian School of Urology, Professor Rajiv Sood, Co-Chairman, Indian School of Urology, Dr. Arun Chawla, the convener of the Endo Subspecialty Section of USI, Dr. Arvind Ganpule, my dear members of the Urological Society of India, residents and members from SAARC countries. Today we are having the second round of this wonderful program, Crossfires in Endourology, conducted by the Urology Subspecialty Session of USI ISU. As you all know, that the first round was a grand success, and there was a good participation from across India and the SAARC countries. And after a very tough debate, we have selected for the second round the participants. Again, the Endourology Subspecialty Session has carved out a wonderful debate journal wise. Today we have between the north and east and west and south, and another session on the residents, and the winners will now go to the round 3. This is a very interesting program, and this has been well appreciated by many in the previous round. Now I wish all the participants a very good luck, and the Endourology Subspecialty Session a grand success. With this few words, I welcome you all again for the round 2 of the Crossfires in Endourology. Thank you.
Good evening to all my friends. I bring greetings from Urology Society of India, and I am very happy to see that Endourology Crossfire debate has reached to the second round. This is a very healthy sign that our members are debating each other, trying to tell their points in a more emphatic and scientific way, and this way everybody is learning. Debate is a very good way of learning, because you hear the viewpoints of two persons talking on same subject with different point of view. So after listening to that, you can take your own call and decide what is best for your patient and what you want to do it. And debate also brings out your desire to argue and desire to bring your own point and desire to win. So this is a competition, and there will be a winner, but we appreciate participation of all the debaters, and we will congratulate the winner, but we also appreciate and congratulate all the participants who have participated in this wonderful webinar. Endourology is a very important aspect of all of us, because it is our bread and butter, and almost all urologists practice endourology, and there are many controversial points which we are debating, and we know there is a different ways of skinning a cat, and one wants to know which is the best way. So by debating, you may get an idea and you may choose the best way to treat your patient. With this, I would like to pray for the good health of all my members, their loved ones, their families. Please stay safe, practice all the safety guidelines, and with this I welcome you again with USI ISU webinar and Crossfire in Endourology round 2, in which West Zone and South Zones will be debating, and participants will be residents and consultant both. Thank you very much.
Good evening, friends. Along with President Anant Kumar, Secretary Dr. Rajiv TP, and my co-chair Dr. Arun Chawla, I extend warm greetings from Indian School of Urology. Endourology subspecialty section, Dr. Ganpule has crafted wonderful program, and we have completed our first phase. That was the round 1 on 16th of December. 23rd of December is going to witness interjonal debates. That will be South versus West and East versus North. And after that, we will be choosing the winners of the debates, and these winners are going to further debate in the third round on 23rd of December. Simultaneously, there are going to be resident rounds, and that is also second round. And in this residence round, which will ultimately conclude in balloon round, this time we are having 3 debates. With this wonderful program, which was conceptualized by Dr. Arvind Ganpule along with the other team members, we are very successfully marching forward in the subspecialty and in the vision of subspecialty based functioning of USI. This is the great times when we are ending our year, and with the greetings for the new year, more academic fees, more academic activities, webinars, distant learning. I wish all the members of Urological Society of India, all the delegates who are witnessing from India, abroad, and especially from SAARC countries, and residents as well as the consultants who are participating, all of you may have happy festivity season, happy more academic activities, and let this corona timings end with the end of this year 2020. Thank you.
Good evening, seniors, friends and colleagues. I am Dr. Arvind Ganpule. I am the convener for this debate program. I welcome you to the USI ISU debate contest round 2. 15 days ago, we had witnessed an academic extravaganza wherein we had got intrazonal debate contests, and we look forward to have an round 2 of a similar academic extravaganza today evening. Today we have an interzonal contest wherein the North Zone debaters will clash with the East Zone debaters and the South Zone will clash with the West Zone debaters. In addition, we have got the Young Turks, that is the residents, who will be debating in Zoom ID 3. So in all, we have got 22 debaters who will be debating in 11 debates. So it's time to enjoy ourselves. All the 3 Zoom IDs will run simultaneously at the same time. The winners of this round enter into the round 3 as well as the grand finale. The debaters are being adjudged by a team of very experienced judges, and I must stop for a second to acknowledge the contribution and services of these judges who are stalwarts in their own field but have agreed to spare their time and have consented to adjudge the winners. Most important, by keeping themselves in anonymity. Thank you, sirs and madam. I must also thank the veteran innovators who have kindly agreed to give us the recorded guest talks. Actually, they do not require any introduction to this august audience. We have got Dr. Mahesh Desai, who will be talking on how the idea of microperk occurred to him. We have got Dr. Janak Desai, who will talk to us as to how the idea of UMP came to him, and then finally Dr. Kaushik Shah would be talking on superperk. Thank you, Mahesh Desai sir, Janak Desai sir, and Kaushik sir for consenting to be on this program. Your talks will indeed inspire the future generation of innovators. I would fail in my duty if I do not acknowledge my colleagues, Dr. Deepak Ragori, Dr. Rahul Gupta, Dr. Singh, and Dr. Zishan, and of course Dr. Karthik from Trichy, who have helped me out in this endeavor. My special thanks to my colleague Dr. Rohan Batra, who has been helping me in the back end. Thanks to Mr. Fani Kumar and Ms. Suruchi Kandalkar from IPCA Laboratories for doing the all back-end job and managing the AV. Professor Raju TP, Professor Raju Sood and Professor Anand Kumar have been the backbone of this program, and I must thank them. Last but not the least, we all will agree that round 1 we witnessed a very few intense, strong and academically robust debates. I must thank all the debaters for preparing so well and for giving their active participation. I wish all the debaters the very best. Thank you.
Thank you, Arvind Ganpule sir, for giving an overview on round 2 of this debate. I will begin the program. So the first debate for today is on a pediatric patient with left renal calculus. I will briefly go through the history. We have a 6-year-old child who had complaints of left flank pain since 6 months without any other complaints, and on examination, findings were normal. The serum creatinine and serum calcium were within normal limits. We had done a plain CT KUB where we had found a stone in the left renal pelvis, which was around 11 mm to 6.3 mm in the longest diameter, and the Hounsfield unit of this stone was around 1150. So this is the excretory urogram of the same child with the normal renal anatomy except for the stones. So we have the debaters for today's first debate. We have Dr. Manoj Kumar Singh, who will speak on ESWL for this child, versus Dr. Rohit Ranjan, who will talk on PCNL for the same child. May I now request Dr. Manoj Kumar Singh to share the screen and start the presentation for the first debate.
So am I visible and audible?
Not yet. Manoj, can you share your screen? You're audible though.
Can you see my slides?
Yeah, I think loading. Yeah, we can see it now. We can make it full screen and start the debate.
Okay.
Yeah, now it's visible.
So good evening to one and all. Welcome on the web. I am Dr. Manoj Kumar Singh from IGMS Patna, and my mentor is Professor Rajesh Tiwari sir. So at the outset, I want to thank USI, Rajiv Tripi sir, Rajiv Sood sir, Chawla sir, Ganpule sir, who gave me a chance to speak on this forum. So let us cross fire again in endourology. So I have no disclosure to make. So this is the patient which we saw as index case, 6 years male child with left renal pelvic stone, 1.1 centimeter of Hounsfield of 1150. It is excreting kidney without hydronephrosis. So just briefly go through the CT. This is the pelvic stone of the given size. Hounsfield is 1150. It is excreting kidney. So I will speak for ESWL in this patient. So before I go for the procedure, I just want to know what the parents want. They want a procedure which can do complete clearance of stone, which is minimally invasive, least morbid, with least complications, faster recovery, and which is cost effective. And this patient fulfills all the criteria. The stone size of 11 mm, the Hounsfield is around 1000. There is no distal obstruction, no hydronephrosis, it is a functioning kidney, and skin to stone distance, and the body surface area is favorable in pediatrics. This is the article by the father of endourology himself, Arthur D. Smith, who has made an outline regarding the management of renal stone on the basis of size. If the size is 1 to 2 centimeter and it is non-polar location, so we can go for ESWL as depicted here. ESWL is a time-tested procedure, as we all know, since inception in 1980 by Chaucy and the first experience by Newman in 1986 on pediatric ESWL. The stone-free rate were more than 80%. It was a great success. What the guidelines say, if you see the AUA 2016 guideline, if the stone size is less than 20 mm, SWL is the first modality of treatment. If you see the guideline by EAU 2019, it has said stone size less than 20 mm, SWL as the first line of therapy, and RIRS nowhere there is PCNL. In this patient, we can also predict the success of ESWL on the basis of this nomogram, on the basis of gender, on the basis of age, stone size, number, location, and the previous intervention. We can also predict the success of ESWL from this nomogram. If you see the anesthesia, younger children we have to go for GA, but the older children we can also go for pseudoanaesthesia in the form of midazolam and propofol. But with the newer generation lithotriptors, more cases are being done under sedation also. So proper positioning, we have to localize the stone with either CM or ultrasound. Proper shielding has to be done if you are using CM. Shock pulse in the power range of 16 to 20 kV. Pulse frequency 60 to 90 per minute. Ramping should be done, means slow escalation of voltage has to be done so that there are smaller fragments and there is less hematoma. Regarding the stone-free rate, there is an article by Mossad et al. In the Arab Journal of Urology. They have said that the final stone-free rate has to be counted after 3 months from the last session of ESWL. That means the first session stone-free rate is not important. At the end of 3 months, the stone-free rate has to be accountable. Regarding the DJ stent, this article has clearly stated that the stone size of less than 2 centimeters, there is no need of DJ if you are concerned about stent receive fever and stone clearance stent if the stone size is less than 2 centimeters. Regarding the stone load and the success of ESWL, if the stone load is less, like in this case, there is single stone 11 mm, the stone's load is less, so the number of sessions required will be less. This is an article by Garg et al. From the KGMU from African Journal of Urology in 2018, which is classified in 2 groups. Group 1, less than 18 years of age. Group 2, more than 18 years of age. And they found out that in pediatric group who were less than 18 years, the stone-free rates, the number of sessions required, the number of shock waves required, the number of ancillary procedures required were less in the group 1, which was the pediatric group. And also they had fewer complications compared to the group who were more than 18 years of age. So they are less hematuria, mild fever, stentress, and sepsis were less in the group 1. Regarding the efficacy of ESWL in children, there had been many studies by Krambeck et al. And studies by Axoy, Groffit, and McClory. All have stated the stone-free rate more than 85%. And the factors responsible for higher stone-free rates were the small body size of the children with shorter stone-to-skin distance, more pliable ureter, and the shorter ureteric length to be traversed for the passage. This is one meta-analysis where the single session stone-free rate were better in the PCNL group. But if you see the complication rate, the fluoroscopy time, and the hospital stay, all were favored for SWL. This is one single center study, 500 cases by Abdel Besse, where the stone-free rate at the end of 3 months were more than 85%, and the need of auxiliary procedure were quite minimal. So advantages over PCNL is ESWL is less invasive, it is less morbid because there is no incision and it avoids urethral route. That is very important. There is less chance of bleeding, chance of infection is less. Stent ratio is less if you do go for ramping, and in this case there is no need of DJ stent, and of course there is less radiation exposure because we are dealing with a child. Shorter procedure time, hospitalization is very less nowadays. Daycare also, return to school will be early. Regarding CKD and renal scarring, there has been studies and many series which have stated that the patients with DMS and DTPS scans have shown no incidence of renal scarring or loss of GFR. Regarding the perinephric hematoma after ESWL, there has been many series and case reports, and they have said that following ESWL for renal calculi, it's very rare, and generally it is benign condition and self-limiting. If you do ramping, then there is less chance of this complication. So if I have to conclude, I will say in this case, I will go for ESWL because the stone-free rate in the both groups are as good as PCNL. It is minimally invasive procedure with least complications. The recovery is faster, and there is least or no radiation exposure, and long-term renal damage
1 minute left.
or less, and of course it is cost effective. Thank you.
Thank you, Manoj. Now you can stop sharing your screen. May I now request Dr. Rohit Ranjan to speak on PCNL for the same case. Dr. Rohit?
Yes, yes. A slide visible, sir?
Yes, you can make it full screen. Yeah.
Just a minute. Good evening, everyone. I'm Dr. Rohit Ranjan from AIMS Rishikesh. I'll be speaking in favor of PCNL. So what are the parents' expectations when they come to us with their kid? All they want a complete stone clearance and return to the normal routine as soon as possible in the most economical and safest way, and of course, a pain-free and healthy life for their kid. So being a urologist, what should be our aim? First of all, we should respect the desire of the parents and offer them the safest procedure with the aim of complete stone clearance in a single procedure with the minimal renal damage and without complication. So what are the determining factors to fulfill all these desires? The first and most important is the anatomy and physiology of the kidney, ureter, and the bladder. Stone composition, HOUNSFIELD units, the time-tested and standard procedure, and availability of the armamentarium, and compliance for the follow-up. So what could be the best treatment for our index case? According to me, it should be percutaneous nephroelthotomy, that is PCNL, and I'll convince you all at the end of my presentation. So as my colleague was saying, is there really any advantage of ESWL over the PCNL for our index case? We will discuss one by one. First, let's talk about the technology. For the pediatric ESWL and pediatric PCNL, both were introduced at the same time in 1986 and 1985, respectively. ESWL became the good choice for the pediatric renal stone disease, but over the period of time, there were minimal advancements that could not be translated to the better outcome. That's why they failed to keep pace and to compete with the other modalities like PCNL, which has got significant improvement over the period of time, like miniaturization of the instruments, the high-power laser disintegration technology, the fine retrieval instruments such as nitinol baskets and the graspers. So ESWL, which is a very costly setup, it will cost many crores, which is not at all cost effective, neither for the hospital nor for the patients. That's why it is available only at the big institutes and mostly used for the residual stones as a secondary procedure. Whereas PCNL, it is affordable and available with all the urologists across the country, and all of them are well trained with this modality, and they use it as the primary monotherapy for all the stone cases. ESWL has got the inferior stone-free rate and higher retreatment rate if it is used for the stone size of more than 10 millimeter. And that's why there are many studies which have suggested if stone size is less than 10 millimeter, we can go ahead with the ESWL. But if stone size is more than 10 millimeter, the only treatment option is PCNL for our index case. With the miniaturization of the TRACT size, there is a decrease in the pain, bleeding, and the hospital stay. Let's talk about the stone-free rate. The ESWL has got a stone-free rate of 44 to 77% for the average stone size of 11.9 millimeter, whereas PCNL has got 94 to 100% for the average stone size of 14.6 millimeter. When we talk about the stone composition, our index case has got high serum calcium towards the higher side. It will be definitely a calcium-based stone, which has got 95% stone clearance rate with the PCNL, whereas ESWL has got only 64%. When ESWL is used for the stone HU of less than 900, the clearance rate is 77%, whereas if HU is more than 900, the stone-free rate is just 33%. That's why there are many studies, including meta-analysis, which says if HU is less than 900, we can use ESWL, but if it is more than 900, we should plan for the PCNL. Additional interventions following ESWL was required in 32% of the kids, which is significantly high. Modalities will be ESWL, PCNL, or URS. The problem is all these procedures will again require the risk of general anesthesia. The residual stones after surgery have been found to be the nidus for the future recurrences, which is much higher following ESWL, which is 18 to 38%. With the miniaturization of the instruments and availability of MINI-PCNL and ultra MINI-PCNL, the risk of bleeding and blood transfusion rate is almost negligible. The MINI-PCNL and ultra MINI-PCNL both are very safe and effective for the pediatric patients, and stone clearance rate is almost similar to the standard PCNL. MINI-PCNL is preferred when age of the kid is less than 10 years, stone size of less than 15 millimeter, and when there is a low BMI kid. There are plenty of studies which compare in the pediatric patient PCNL versus ESWL. And they concluded that PCNL has got the highest, whereas the ESWL has got the lowest success and stone-free rate. And when we talk about the complications following ESWL, the bruising, ecchymosis, subcapsular hematoma, hematuria, and the renal colic was seen in 11 to 50% of the cases. Stene stress rate was 7 to 9%, whereas ureteral obstruction was seen in 5 to 7% of the cases. But the problem is that in these two complications, patient will require degestanting, and that will be done under general anesthesia only. And subsequent removal will also require anesthesia. But these are small kids of 5 to 6 years of age. In India, recurrence is the major problem, as follow-up is not assured due to poor socioeconomics. So any small residual calculus can no longer be considered insignificant for the fear of recurrence. That's why ESWL has got the highest retreatment rates, requiring more ancillary procedure, whereas the PCNL, it fulfills the purpose of the stone clearance with a minimal morbidity and a single hospital stay. When we talk about the cost effective, PCNL is the most cost effective than ESWL for the stone size of less than 2 centimeters for both patient as well as for the hospital, because PCNL gives the opportunity to treat the complete disease in a single setting, whereas ESWL will require multiple sessions of the treatment. Following ESWL, there are adverse effects on the organ development also, like alteration in the renal growth pattern, and that will cause relatively smaller kidney on the treated side compared to the contralateral side. There are 40% increased risk of developing hypertension and diabetes. And average age of these kids at the time of treatment was 10 years, and follow-up was done for next 8 to 19 years. Although, as my colleague was saying, it is not like that, and there are controversial evidences also, but they said there was no or mild effect. Mean age of these kids
1 minute left,
and follow-up period was less than 3 years. There was no significant loss of nephrons following PCNL. As the era of ESWL has gone down, there is a rising trend of using PCNL and RIRS. So I conclude my talk. The ultimate target of pediatric stone management is to achieve extreme stone clearance with a safe and effective therapeutic regimen. Over the last 2 decades, the We have witnessed the improved outcome and the lower morbidity rates in the children following PCNL because there are refinements in the percutaneous access technique, the miniaturization of the instruments, and the technological advances in energy source for the intracorporeal lithotripsy. And that's why PCNL has become the mainstay for the treatment of the pediatric renal stone disease, and it has gradually replacing the ESWL. Thank you.
Thank you, Dr. Rohit. Now you can stop sharing your screen. May I now request Dr. Manoj Kumar for a brief rebuttal of 2 minutes.
I will share my slide.
Yeah.
Is my slide visible, sir?
Yes, it is.
Okay. So my friend were saying that a 6-year child, a left pelvic stone, will do PCNL, and he has many literature to prove that there is a better modality of choice. I would say a 6-year child is at risk of recurrent stone formation. He may have a metabolic abnormality, recurrent infection due to VUR, and formation of recurrent stone. So the long-term risk of radiation and renal damage is always there. And if you have done PCNL at the age of 6 years, the future risk is always associated, number one. Number two is the bleeding. There are many studies, and this is a study from CMC Belord by Dr. Nitin Kekre sir. He has clearly said that adult instrument which we use for the pediatric patient also, because MINI-PCNL and micro are not universal instruments which are in all the setups. So, and there the chance of bleeding is a lot in pediatric kidneys. And the body reserve in children is very less. So 1 gram hemoglobin drop also is a lot to ask for them, number two. Number three, this is an article by Mahesh Desai sir, who has also said that rep size more than 16.5 frames, the risk of bleeding, infection, and major complication will be more. And if warrant use of high pulse energy, wider bubble will increase the risk of thermal injury. The temperature in the calyx may go as high as 43 degrees and will cause thermal injury. So this has been one study in the porcine model where there was thermal injury of calyx, and finally MINI-PCNL will give rise to higher intrapelvic pressure causing pylovenous reflux and the pharyngeal rupture. Thank you. So I will bid for ESWL in this case.
Thank you, Manoj. Now I request Dr. Rohit to come back with a rebuttal for 2 minutes.
Is my screen visible, sir?
Yes, it is.
Earlier, PCNL was used for the larger stones only, but with the availability of miniaturization of the instruments like MINI-PCNL and ultra MINI-PCNL, we got the opportunity to treat the smaller stone of size less than 20 millimeter, and that has got a stone-free rate after single procedure up to 94 to 100%. And all these procedures can be tubeless or totally tubeless. When we compare ESWL versus MINI-PCNL for the renal pelvic stone, similar to our index case, the stone size and age was comparable. There was no need for blood transfusion in any of the group. The need for auxiliary procedures was significantly higher in the ESWL group, which was 11.5%, whereas in the MINI-PCNL group, it was just 2.6%. That second session was required in the 46% of the cases following ESWL, whereas it was just 7% for the MINI-PCNL, which was significant. The stone-free rate after single session was just 50% for the ESWL group, whereas it was almost close to the 90% for the MINI-PCNL group. So these studies, they recommend using MINI-PCNL for the treatment of the renal pelvic stone of size 10 to 20 millimeter in children because of its higher stone-free rate in a single setting without compromising the safety. So what are the predictors for the failure of ESWL? First, the stone size of more than 10 millimeter, HU of more than 900, and any anatomical abnormality. When we talk about the index case, it has got 11 millimeter of the stone with the 1150 HU, and when we see the
30 seconds left.
photography, we can see the dilated ureter and the tortuosity. That's why ESWL cannot be used and not indicated for this index case. So I conclude my talk, ESWL is serving only one good for this patient, that decrease hospital stay by 12 to 18 hours, whereas PCNL is giving the complete stone clearance in a single setting and can be used for the harder stone in presence of anatomical abnormality, and it is very easily available in a cost-effective manner. And best thing is that it is totally
over.
Urologist. Thank you. I still go in favor of PCNL for this index case.
Thank you, Dr. Rohit. Now we move on to our next debate. Rohit, can you stop sharing the screen?
Yes, sir.
Thank you. So now we move on to the second debate, which is on supine versus prone PCNL. So briefly, I'll introduce the case to you all. We have a 68-year female who is hypertensive since 10 years. She complains of left flank pain since 2 to 3 years on and off, associated with nausea. Her abdomen findings were normal. Her BMI was 28 kilogram per meter square. This is a CT images. You can see on axial cut, the greatest diameter of left pelvic kidney stone is 12.3 mm and 15.4 mm. And on the coronal cut, you can see 17.5 mm is the greatest diameter. The Hounsfield unit of this stone is around 1350. And you can see the 3D reconstructed images below, where you can see a left renal pelvic stone of almost 17 into 15 millimeter. For this debate, we have Dr. Abhi Shegde, who will be speaking on prone PCNL, and Dr. Manharsin Rajput will speak on supine PCNL. May I now request Dr. Abhi Shegde to come and start the debate with his proponents for prone PCNL.
Hello?
Yeah, Abhish.
Am I audible, sir, and my slides visible?
Yes, go on, please.
Okay. Sir, I want to minimize, there's something on the Zoom is coming. Okay. Can I start, sir?
Go on, you can start now.
I'm Dr. Abhish from Topiwala Medical College, and under the guidance of Dr. Hemant Pathak and Dr. Mukund Andankar, I am here to present for PCNL for the given case, the prone PCNL. The outline of my talk, I'll be dealing with the technical aspects of a female patient with the left pelvic calculus with the anatomy and the stone burden that is given to us, who is also overweight, the anesthetic concerns of such a patient who is overweight and hypertensive with regard to the following parameters, and the results and complications given with prone PCNL. The problems that we have with an increased BMI of a patient is that the anatomical landmarks are obscured and the tract placement is difficult. Depth of the tract significantly increases, along with hemodynamical and ventilation concerns for the anesthetist. Also, there is a possible attenuation of the image quality. In practice, we use long sheets with sutured tails, that we also choose the shortest possible tract and use extra long instruments, and prefer to leave a nephroureterostomy tube that helps in avoiding the dislodgement of the nephroureterostomy tube. Prone PCNL has been established as the most commonly used position by the Crow study. It also provides direct access to the favorably located posterior calyces. Any of the polar location is easily accessible. Upper pole calyx is anatomically closest to the skin in the prone position. Ready access to the proximal ureter and entire collecting system can be taken with an upper pole calyceal puncture, especially with the anatomy that is given to us, wherein the mobile lower calyces and the middle calyx will align itself to the tract and the rigid nephroscope. Prone position has also been proven by Kehilia et al. To be well tolerated even at the extremes of BMI. Advantages are the dilatation is easier in a fixed upper pole because of Gerota's attachments, which are highest in the upper pole. It reduces renal parenchymal shear and hence the bleeding. Bilateral procedures as well as multiple accesses are possible. There is proven higher success rates and faster access compared to supine and flank position in the study done by Karami et al. For prone PCNL. This is my patient whom I would like to take an upper calyceal puncture, which is in line with the ureter and the axis of the kidney and gives me a certain degree of freedom of movement with prone PCNL. I would also take care to adequately pad the pressure points in this patient. There has been reports that have told us about awake endotracheal intubation with topical anesthesia, following which the patient self-positions himself in the prone position and tells us where the extra padding is required for the pressure points. There have also been reports that have described CPR in the prone position. Pelosi et al. Have established that prone position in general anesthesia minimally affects the respiratory mechanics while improving functional residual capacity and increasing the oxygen tension. Sieve et al., who looked at the peak inspiratory pressure in the prone position, according to patients with a raised body mass index, have also predicted that there is higher baseline peak inspiratory pressure in all of these patients, regardless of the position, and prone positioning does not impact the peak inspiratory pressure. To further assay the fears of my anesthetist, Edgecombe et al. Has also described a review of anesthesia in the prone position where they have improved and established the fact that prone PCNL is safe in the prone position. The supine position they have described exacerbates the borderline cardiac reserve, especially because the increased abdominal pressure due to the abdominal pannus decreases the pulmonary compliance and there is a larger ventilation perfusion mismatch. Further modifications can be done to reassure my anesthetist, that is the ET view that can help in continuous monitoring of the ET tube in the change of posture during the procedure, the ProNew helmet that can help in padding the adequate pressure points, as well as the cervical spine stabilization. This is another modification, a Montreal mattress that can be used to help the abdominal pannus to hang freely, along with access to the perineum with the gentle slope and easy padding rather than the multiple pads that can be used. Also, we can use the Wilson frame. Ray et al., in their description of a modification of the prone position, that is the prone flex position, have told us that patients in this position can require repositioning immediately after intubation, but needs to be draped only once because the perineum is still free for access. The working space is further increased and eliminates interference from the buttock, especially so if we intend to take a low glacial puncture. The spleen has been found to be displaced laterally and the kidneys inferiorly in this paper. It is the effects that have been described are most pronounced to the left kidney, which is also what we have in our patient given today. Also, the supra 12th puncture can be converted to an infracostal access with this method. And out of the 180 patients that they studied, there was no requirement of transfusion in any patient. The lateral approach, they said, in supine position can injure the colon. This is how the entire back is now open and the buttock is away from our puncture site. Hamamoto et al. Have described the prone split leg position that describes the simultaneous antegrade and retrograde access that is possible, especially so for female patients initially, which was expanded by Dr. Schoenberg et al. In their landmark paper, and they provided all the tricks of the trade, especially so for male patients. I would like to show you how in the supine position, the kidney, the lower pole, both the poles are further away from the skin as regard to the stone skin distance, which is 11.4 centimeter, whereas in the prone or the prone flex position, the stone skin distance significantly decreases. Also, with alignment of the kidney with towards the angle of the ureter as well as the pelvic ileal system. The EAU guidelines also reiterate the fact that prone position offers more options for puncture and is hence preferred for upper pole or multiple accesses. Dr. Joe Spaldivia et al., who paradoxically propagated the idea of supine PCNL, has started the largest prospective study on PCNL from a report from the Clinical Research Office of the Endouro5 Society, and they studied 5,775 patients, wherein they established that 80% of all patients underwent prone PCNL, and especially so in Asia, where 98% of patients underwent prone PCNL. They found that the mean operative time was lower in prone PCNL with a significantly high stone-free rate in prone posture. There were lower failed access procedures in prone PCNL and more upper calyceal access and multiple punctures were possible in these patients, which translated to more incidence of transfusion. USG could be used as a sole method of calyceal access in case of prone posture compared to that of supine, and failed procedures were more in case of supine patients. If you look at data from supine only centers and versus those practicing prone only PCNL, again, the stone-free rate as well as operative time favored the prone only position. The CROWS study, when stratified for body mass index, found that there was no increased use of supine position in the obese patient and no difference in pulmonary or hemorrhagic complications in these patients. If you look at multiple prospective as well as meta-analysis data over time, it has been established again that the stone-free rates are higher for prone PCNL versus the modified supine or the supine PCNL, along with shorter operative time. Giusti et al. In their latest prospective trial have established that the prone split leg position has equivalent retrograde access as compared to the supine of the double supine position, as well as the males were benefited by this access. Prone also had a lesser time to access from the time of puncture. In conclusion, I would like to submit that for the given patient, the overweight female patient who is hypertensive with the pelvic calculus, with the pelvic ileal anatomy that is described, Prone PCNL is versatile and is a time-tested approach with freedom of access and maneuverability. We, as urologists, have been programmed for PCNL in the prone position from our training as well as practice. Individual modifications have all been available, and this approach is beneficial in overweight and has been established to provide better stone-free rates. Thank you.
Thank you, Avish. Now, may I request Dr. Manhar Singh Rajput to speak on supine PCNL for this case. Manhar Singh, you can start sharing your screen.
Yes, sir. Is my slide visible, sir?
Yes, and you're audible too. You can go ahead. You can make it full screen and go ahead.
Just a minute. Can you see my slide?
Yes.
Okay.
Please go on.
Okay. Good evening, everyone. I am speaking in favor of supine position, PCNL and supine position for a renal pelvic stone. So here we have a 68-year elderly female patient with comorbidities like hypertension and overweight. Patient has cardiovascular risk and patient comes under ASA category 3. So this patient may not tolerate longer procedure, and patient may have hemodynamic effects of anesthesia in a prone position. So in this case, my choice of procedure would be supine PCNL because number one, patient safety, number two, patient safety, and number three is patient safety. So initially, prone position was started by radiologists where they used to puncture hydronephrotic kidney, and then during that time there were no CT scans, so we didn't know about the position of colon. So urologists followed the same trend, and we started doing PCNL in a prone position. So first was done by the Dr. Funstrom and Johansson in 1976, and then it was modified by Dr. Valdivia in 1987. But I'm surprised that currently only 20% centers are performing supine PCNL. Maybe because there is lack of training in supine PCNL, that may be the reason. There are variations in the positions of supine in the supine, and each and every position has their pros and cons. But the most important point I would like to make here is we have to do the puncture behind the posterior axial line, which is our Lakshman Rekha, and other landmarks are 12th rib and iliac crest. So this procedure has number of advantages, starting from the patient's position, where it reduces the risk of musculoskeletal and visual complications. It allows the optimal airway control. In case of emergency, it is easy to give provide immediate resuscitations, and there is no chance of endotracheal tube compression or any other dislodgement. Definitely in this case, we don't need to change the position, so definitely we are saving time over there. And it is absolutely indicated in the patients with spinal deformities and certain cases like motor neuron disease, morbid obesity, and respiratory issues. It is preferred. There is less chance of colonic injuries, and as you can see here, cases of retrorenal colon has been found in 1.9% person compared to the prone position where it is 10%. There is egress of passive egress of fluid from the horizontal sheath, so there is less pressure buildup and reduces the postoperative fever and sepsis complications. We can also do simultaneous retrograde access, and puncture is relatively lateral, so we can access both the anterior as well as posterior calyces. For the surgeon, you can see here, we can sit down comfortability and we can operate on the patient with less risk of radiation exposure. Most of the punctures are subcostal, but superior punctures are easily possible. And so far, et al. Has demonstrated that it is possible to reach upper calyx from lower calyx in almost 80% of cases. As our sheath is horizontal, there is spontaneous stone drainage, and there is no problem regarding residual fragments. It can easily drain out during the procedure. So let's see what evidence says. When I started literature search, I came across 160 articles in PubMed, as you can see here. So as we have seen, there are so many advantages, but what is still preventing us to choose supine position? So as a urologist, we are worried about two things. If we are going for any procedure, then will I be able to provide a equal stone-free rate compared to the prone position? And second is, will there be complications? So if I say yes, you can make your patient stone-free with less complications, then will you go for this procedure? I think almost more than 90% people will agree to this. So let's see what meta-analysis says. First, I will start with the meta-analysis published in 2019, where 15 RCTs and 1470.4 patients were included. And it concluded that there are comparable stone-free rate and significant lower rate of postoperative fever in supine PCNL. And they concluded that it is safe and efficient choice of for the patient with renal and upper ureteric calculi. Second meta-analysis, which included 4 clinical comparative studies and 27 case series, which also says that for renal calculi, operative time is less, stone-free rate is equal, and there is less complication in supine PCNL. One more meta-analysis where 389 patients were included, and this also says the same thing. And they concluded that supine position is effective and safe as PCNL is an alternative option for removal of renal calculi in PCNL. Now let's go to comparative studies. In this study, 3 different supine positions were compared with the prone position, and they also found that the position does not impact rate of success and severe complication that we all are worried about. Next, experience from a single center. They have also found the same thing, that stone clearance and complication rates are equal, and it decreases the operation time. So are there any hemodynamic and ventilatory changes? Yes, there are. You can see here there is significant difference in peak airway pressure, mean blood pressure, and heart rate in both the procedures. And in patients with ASA category 3 and 4, it may represent more than just the theoretical risk of serious morbidity. Another study, excellent study, where compared hemodynamic and metabolic changes were compared, and you can see here fluid absorption rate was higher in prone position, and there was statistically significant difference between mean systolic blood pressure and diastolic blood pressure change. So supine PCNL has less hemodynamic changes, less hypotension, less bleeding, and less need for blood transfusion and better control of airways. Study from India where PCNL was done, supine PCNL was done in high risk cases, and they have also concluded that it is as effective and safe procedure in high risk and obese patients also. So are there any other studies from India? Yes, there are a number of studies from India on supine PCNL, and if I have to summarize all the studies in a one sentence, then that would be that supine position is a safe and effective compared to the prone, with less complications and equal stone-free rate. So is there any reason left for not going for supine PCNL in a given case? I'd conclude my talk by saying that it's a part of evaluation. It enables safe procedure from an anesthetic, surgeon, as well as patient's point of view. In that, we can combine antegrade as well as retrograde surgery. It is non-inferior to prone PCNL, and it has potential for replacing prone approach for most of the renal stone cases in experienced hands. So we should start learning supine position, supine PCNL, and we should also perform it in certain cases like the one given here today. Thank you.
Thank you, Manhar Singh. Now I request Dr. Abhish Hegde to present his rebuttal for 2 minutes. Manhar Singh, yeah. Abhish, can you share your screen?
Is my slide visible, sir? And am I audible?
Yeah.
Hello? Hello?
Yeah, go on. We can hear you.
It's a slideshow now?
Yes.
Is it okay?
Yes,
okay,
yes.
I shall start. I will be able to tell the drawbacks that my friend has concealed from the public view. There is a limited surface area for renal puncture and instrument manipulation in supine PCNL, with difficulty in accessing the upper pole. The longer tract length, which is of concern in my overweight patient today. The colon, my friend, is at risk only at the lower pole axis, which you would be mostly taking with the supine PCNL. Anterior calycial puncture is what you would do in a supine PCNL, which is again a dangerous proposition for the patient. The pleura is lower in the anterior intercostal space. The puncture and dilatation is difficult because of the hypermobile kidney, as shown before. There is impaired visualization because of the lower internal pressure due to the access sheath, which is downward in orientation, which is further impaired by aspiration with an ultrasonic probe. The fragments, my dear friend, collect in the dependent posterior calyces. What are you going to do about them? What about the significant learning curve of almost 60 cases in literature for supine PCNL? This is the anterior puncture with such a limited mobility for your scope in this posture with uncomfortable patient characteristics. My friend, how are you going to take an upper calycial puncture, which is most suitable for this patient with the anatomy given to us? What about the acute angle that the lower calyx has with the alignment of the ureter? And what about this bowel loop that is sitting right in front of your tract? The patient factors that are given to me, the stone score that has been calculated, I will be able to confidently give a stone-free rate of 92% for this patient. With an increased tract length with supine PCNL, the rates would drop to 64%. I am concerned. The same data that you have quoted, my friend, has also acknowledged the fact that higher stone-free rate is possible in prone PCNL, and the experienced surgeons are required for supine PCNL with poor quality of RCTs. Prone PCNL is still the gold standard, is acknowledged in a monogram published for nephrolithotomy and ECIRS and a review later. It is a gold standard. The title is for you, my dear friend. Prone PCNL is easy, safe in access and dilatation, and a shorter tract with larger field for obese patients, especially this given to me with a regularly used skill. The extra time is a small investment for the safety. Change is dictated by necessity and not luxury. I rest my case.
Thank you, Abish. Now I request Manar Singh Rajput to give a brief rebuttal for 2 minutes.
Is my slide visible, sir?
Yes, and you're audible too.
Hello, sir.
Yeah, it's visible.
So, Abhis, you mentioned about PCNL global study. In that, Dr. Valdivia has mentioned that ECIRS and regarding ASA grades have not been mentioned, so we don't know about that. And second is modifications you have shown. Is it available in India, and how many places you can use that? Can you see me, sir?
Yeah, your slides are not moving. You can click
Yeah,
on
now not moving, sir. Slides are not moving, sir.
Is it loading?
I'll share again, sir.
Yeah, share again. No problem.
Can you see it, sir?
No, no. So Manar, if you have any issues, what we'll do is we'll go with the third debate. Yeah, we can see your screen now.
Yes, sir.
Yes.
Yeah. So Dr. Abish has said about PCNL global study by Dr. Valdivia. In that ECI, the sir has already said that ECRS had not been mentioned in that, whether it was used in supine group. Second is ASA category has not been mentioned, and modification you have shown, is it available in India? Second is this procedure has been criticized for so many reasons, and Abish has nicely pointed out, but I will have solution for everything. One is regarding the kidney mobility. You can give a counter pressure or you can puncture in maximal aspiration, or you can use a through and through guide wire. Second is vision problem during nephroscopy. You can use additional irrigation, saline bag elevation, or you can use saline bag elevation. The most controversial thing regards to superior calyceal puncture, you can see here it can be nicely done. And in case of difficulty, you can use ureteroscopy or flexible nephroscope, or you can approach upper calyx through lower calyx as well. Longer track length, not an issue. You can use extra long equipments. There is no issue of restricted working space, because if you keep the patient near the border of a table or a pillow. So this is the scene of every operation theater where we need number of people to change the patient's position. There is more OT turnaround time, and there are risk of pressure injuries due to inaccurate positioning. There are a number of reported cases of post-operative visual loss, and if this happens in Indian setup, then we know the consequences of this. And so we have to evaluate our patient in an elderly patient, such as given to us, the case given to
30
us
seconds left.
going for the procedure, and there are reported cases of focal neuropathy. So prone position reduces the cardiac index by 24%. There are ventilatory problems. There are difficult retrograde access. High risk of X-ray exposure, worse residual fragment evacuation, and slightly higher risk of colonic injury. Thank you.
Thank you, Manar. Now we can stop sharing your screen. Now we move on to the next debate. So the last and the final debate is on a calyceal diverticular calculus. We have a 32-year-old female without any comorbidities who had on and off flank pain on the right side since 1 year. Abdominal findings were normal. The CT scan showed 11 to 8 millimeter calculus. And when we had a reconstruction of the same CT, it showed a calyceal diverticulum with 11 into 8 millimeter stone on the right side with 1100 Hounsfield unit. So this debate will be discussed between Aditya Gupta, who will speak in favor of RARS, and Dr. Sepuri Raviteja will speak on PCNL. Now, may I request Dr. Aditya Gupta to start the debate with his talk in favor of RARS for this case.
Yes, sir.
can you see my screen?
Yes, Aditya, we can see your screen and you're audible too.
Okay, okay. So we'll start, sir.
Yeah, please go on.
Good evening, everyone. I am Dr. Aditya, and I will be speaking in favor of RIRS for this case. There are no conflicts of interest. We have already seen the case. This is the CD. Now let us see the salient points. There is a single 11 by 8 mm calculus of approximately 1100 Hounsfield units in the anterior diverticulum of the middle calyx. The overlying kidney parenchyma over the anterior diverticulum appears to be thin, whereas over the posterior calyx it appears to be thick. There's the problem of liver, which appears to surround the kidney, which will create problem during percutaneous access. And she's a female patient. Now, given treatment options, either PCNL or RIRS. Now, before giving any final decision on the treatment, I would like to answer these three questions. What is the feasibility of this surgery? What are the complication rates? And what are the stone-free rates? According to EAU guidelines, for 10 to 20 mm renal stones, either ESWL or endourology can be done. However, it does not say that which one is better. But the complication rates of ureteroscopy in the guidelines range from 9 to 25%, with most of them minor. Whereas for PCNL, approximately 11% patients have fever, 7% have need for blood transfusion, 1.5% have thoracic complications, and less than 0.5% have sepsis, organ injuries, and others. Now we'll consider PCNL for this patient. So according to Guy's score, this belongs to grade 3 because stones are present in the calyceal diverticulum. According to this study, they decided the stone-free rate according to the different Guy's score grades and found that for grade 3, the stone-free rate was only 35%. Now, this study validated the complication rates with the various Guy's stone score and found that for Guy's stone score 3 and 4, it was associated with higher complications. Now, even though besides that we want to do a PCNL, so there are two options, either an anterior or a posterior puncture. Now let us first see the direct anterior puncture. What are the problems? First, as told, the liver is seen to be surrounding the kidney. Now I understand this is just one cut, it might not be so. So we go toward the second point. The diverticulum is quite small, with most of it being occupied by a large stone. Parking of guide wire in such a case is very difficult, leading to loss of tract and hemorrhage. There's always a risk of leak because of the overlying thin parenchyma. Now, there's always the problem of PCN. Where do you put it? For how long? Do you ablate the calyceal diverticulum? Do you open the calyceal diverticular orifice? What to do? So these findings were echoed by this review study in which 100 cases were reviewed, and they finally they concluded that direct PCN access to a diverticulum is always associated with a risk for inadvertent total loss of access. A treatment algorithm was made by them. Let us see how our patient fares in this. Now, our patient is having an anterior diverticulum in the middle calyx, having an 11 by 8 mm calculus. So according to this, the treatment option should be flexible ureteroscopy. Another study was published with compared the complications of percutaneous of PCNL between the anterior and the posterior calyceal stones, and it was found that the anterior calyceal puncture was always associated with greater post-op hemoglobin drop, need for blood transfusion. So after going through the literature, we decided to do a posterior calyceal puncture. Let us see what are the problems. Again, liver might be there. Now, the main problem is the calyx appears to be absolutely non-dilated. Puncturing such a calyx is quite difficult. If somehow we manage to do it, there's the problem of a very narrow infundibulum. To reach the anterior diverticular orifice, we need to transverse this, and it will 100% cause tear and bleeding. Also, the torque to the kidney to reach the diverticulum will cause further problems. A study by Mahesh Desai et al., they predicted the factors which was causing increased blood loss during PCNL and found that the parenchymal thickness of greater than 10 mm had a higher hemoglobin drop. Now the stone size is 10 mm, and so we can say that the parenchymal thickness must be more than that. Now this comes to our second option, RIRS. Now, most of the times we will be able to identify the diverticular orifice, but sometimes it becomes difficult. So what are the methods? Combined flexible URS and fluoroscopy, which we'll see. Most of the time there is an erythematous membrane which is present at the diverticular orifice. stone might be visible. Now, there's one very interesting technique which is called the blue spritz technique, in which the methylene blue is instilled into the collecting system while placing the flexible scope near the suspected calyx. The dye is suctioned out. Once the saline irrigation is reinstilled, the residual blue dye from the diverticulum would escape. And if everything fails, then USG and fluoroscopic guided puncture. This is a video. Now here you can see that combined RIRS and CM was used to locate the diverticular orifice. The diverticular orifice with the help of laser was incised completely. And we have entered the diverticulum and the stone is visualized. Now the best part of RIRS in such a patient is that during fragmentation, this stone is not going to migrate out. So we can easily do fragmentation and laser dusting. So let us see what are the stone-free rates according to studies. The stone-free rate of various studies have been successful by 80 to 90%, and the complication rates are around 10%, which were all managed conservatively. Let us see whether there were any comparison studies between PCNL and RIRS. So there was this study published in 2015 having 54 patients. They found that the success rate for PCNL was 90%, whereas that for a flexible URS was 85%. However, they were not able to do in 2 patients flexible URS because of the limited deflection towards the lower pole. So hospitalization time was much less in a flexible URS. The problem was that the grade 3 complications in PCNL was almost up to the range of 10%, and 7% had blood transfusion requirement. One more thing, one patient who had anterior calyceal diverticula was converted to open surgery due to excessive bleeding. There are various studies in the literature and different studies having the same conclusion, that though PCNL having stone-free rate a little bit higher, it is technically demanding with higher rate of complications. RIRS using a holmium laser is a very, very effective technique, particularly for the anterior calyceal diverticular stone. Now, our patient has a single 11 by 8 mm calculus in the anterior diverticulum of the middle calyx. The question here is not why RIRS. The question here is why not RIRS. Now,
1 minute left.
If you don't want your patient to run away, then instead of PCNL, had there been RIRS written, that the patient would have gone with the urologist. I'll rest my case. Thank you.
Thank you, Aditya. Now I request Dr. Ravi Teja to share his screen and speak in favor of PCNL for this calyceal diverticular stone.
Good evening, sir. Are you able to see my screen?
Yes, Ravi Teja, you can go on.
Yeah. I will debate for PCNLs in the case as my colleague had explained regarding the case 11 cross 8 mm and 1100 HU. And my management will be in the form of either PCNL or MINI-PCNL. As stated by Drawbacks et al., complicated diverticular calculus needs PCNL. And we'll see what is calcial diverticular calculus. It is urothelium line non-secretory thing, and it should be cleared completely because the chance of recurrent infection and pain is there. And as per Campbell, PCNL should be considered first-line treatment for most calcial diverticular stones. And with PCNL, stone-free rates are around 70 to 100%, whereas with RIRS, it is only 50 to 90%. And the main thing is symptom-free score for PCNL is 77 to 100%, whereas for RIRS, it is only 35%, which is almost half that of PCNL. And rigid instruments will provide a superior visualization compared to the flexible thing. And the main thing is diverticular obliteration, which will be more adequate with percutaneous approach, which is more than 70%, whereas with ureteroscopic approach, it is only 20%. So here we are not treating the cause. And we'll see why PCNL is preferred here. We can directly puncture the calcium diverticulum. And for example, if the same patient has been undergone RIRS, if you are not able to identify the ostium, or if you are blindly incising and if you are not able to reach the diverticulum, it will end up in a failure thing. And before doing RIRS, we have to pre-stent the patient so that the ureteral access sheath and all will be inserted. So instead of 2 procedures, we can clear the stone in a single sitting. And the main thing is cauterization of or fulguration of the urothelium can be done in the same sitting, even if you are not able to identify the ostium. And dilatation of the diverticular neck can be needed if required. And overall stone-free rates are inferior with RIRS than PCNL as per Campbell. And as per the given image, we are not sure about the communication or opening of the diverticulum with the collecting system. So chance of failure is more with RIRS than PCNL. And I'd like to show some of the studies. This is a multi-centered study in India, which showed the stone-free rate of around 95% and complete diverticular resolution in 95% of the patients with PCNL. Out of these 44 patients, in the 8 patients, they were not able to identify the calcial opening. But despite that, they were able to clear the stone, which my colleague had told that blue spirit technique. They have used that, but they were not able to identify the opening. If the same patients have been undergone RARS, the calculus couldn't be reached and it would have ended in failure. This one more article published in Journal of Urology. Here, PCNL was successful in 96% of the patients with 4% complication rate that were cleaved into grade 1 to 2. And the main thing is, in a follow-up period, 46 patients showed complete absence of diverticulum and 5 patients showed reduction in the size of diverticulum, which is unlikely with RARS. And they have stated that percutaneous treatment is safe and effective regardless of size, location, and including anterior diverticula. This is a meta-analysis, and they have stated that percutaneous management is best used in mid to lower polar stone and offers ability to directly ablate the diverticulum. And in their study, the meta-analysis, they have suggested that ostium cannot be identified in 30% of the patients while undergoing RARS. And these are the studies. Here you can see almost 80 to 90% of obliteration of diverticulum and stone-free rate of around more than 90%. And you can see the follow-up period. It is more than 1 year in all the things. And the same thing here. When we search for RARS studies, there are only 5 studies. And the thing is, obliteration of diverticulum was not documented in most of the studies. And if it is documented, it is very less, like 7% and 18%. And successful entry in the diverticulum is around 70%. And the length of follow-up also, if you see, it is hardly like 3-4 months. And in this study also, Chang et al. It's a single-center study without any obliteration of diverticulum or symptom-free. The main thing is symptom-free. And in Bratter and Drettel study, they were not able to enter the diverticulum in 8 cases out of 26 cases. And in Fritz and David, they have combined RARS with in situ ESWL. And this is analysis between PCNL and ureteroscopy. Here, 22 patients underwent PCNL and 17 underwent RARS. 35% of the RARS were symptom-free, but 86% of the PCNL were completely symptom-free. And out of the 17 patients, 7 patients underwent PCNL for ultimate success, because 4 of them, in 4 of them, they couldn't identify the ostium and they couldn't enter the cavity. And in the same study, stone-free rates were around 78% with PCNL, whereas with RARS, it is only 19%, which is a gross difference. This is systematic review of calcial diverticulum. Here they have studied 1181 articles, where 153 patients underwent RARS and 487 patients underwent PCNL. And the stone-free rates were around 61% with RARS, whereas 83% with PCNL. And the complication rates were almost similar, 8.3 and 12%. And this is a study comparing MINI-PCNL and RARS, where the stone-free rates after MINI-PCNL is around 90%, whereas with RARS is around 60%. And 71% of the patients had symptomatic improvement at 6 months follow-up. And the complications rate with PCNL is 19%, whereas with RARS it is 13%. And the main thing is complete diverticular obliteration was achieved in 76% in MINI-PCNL and only in 33% in flexible URS group. And coming to the EUA guidelines, they are documented that symptomatic calcial diverticular stones can be treated endoscopically, either PCNL or URS or laparoscopy or robotic. They didn't document which is preferable, but stone-free rates are 18 to 90% with RARS. You can see the lower limit, it is only 18%. Whereas in the PCNL, it is 62 to 100%. And one more thing is, an endoscopic approach also permits correction of anatomic abnormality, which is the reason for the stone formation. That is highest with PCNL, and in this statement, they didn't include anywhere about RARS. And my colleague has suggested regarding complications, but all the studies, they were comparing PCNL with RARS. Now, as the technology had advanced, we can use MINI-PCNL, which will have lesser complications than the standard PCNL. These are the references. Thank you.
Thank you, Ravi Teja. Now I request Dr. Aditya Gupta to give a brief rebuttal for 2 minutes.
Yes, sir. Yes, sir. Sir, am I visible and is my screen visible?
No, not yet. I think you should open your PowerPoint first and then share the screen.
Sir, 1 minute, sir. Yes. 1 minute. Sir, now is my screen visible?
Yeah, it is. Make it full screen.
Okay. Now,
Yeah.
is it visible?
Yeah, please go on.
Yes. So, yes, as my colleague has said, now he was very much interested in the diverticular obliteration. My dear friend, diverticular obliteration is possible in RIRS. What you are doing, you are taking out the cause, and that is the narrow calycial diverticular orifice. Anyways, now he has quoted many studies, but which were older. My questions were: what is the year of publication? What is the mode of percutaneous access? Interventional radiologist or urologist did it? What was the location of the stone? What is the stone-free rate of anterior and posterior diverticula and their individual complication rates? Failure rates for which stone locations were more in RIRS? Now, there are various studies, I agree, having lesser SFR, but if you study them, it is because the stones were located in lower calyx, large size and multiple stones were included, and availability of lesser deflection of scopes and lower resolutions causing high failure rates. Now, this study, which we have many times quoted about this Brian K. Orb, now I like to tell you, it was published in 2002, and the study period was 94 to 2001. SFR, I agree, was 19%. Now, what are the drawbacks? PCNL was done by an interventional radiologist. Patients were not randomized. Before 97, EHL was used to break the stones. Out of 17 patients, 4 had 3 by 3 centimeter calculi and 2 had multiple calculi. Even with this, they concluded that there's an advantage of PCN over URS for complex posterior diverticular stones, although with a slightly increased risk of complications. Now, comparing this old studies is like comparing a Tesla with fuels and cars by quoting comparison studies with REVA. Anyways, all the study of previous decades and latest one agree to this point that RIRS is the treatment of choice for single stone less than 1.5 centimeters, especially for stones in anterior diverticulum and upper and middle calyx, which is our patient. So I am not giving a blanket statement that RIRS is better for renal stones than PCNL, but for our index patient, it is the best and it is a boon. So kindly consider it, my friend. Thank you.
Thank you, Aditya. Now I request Ravi Teja for a brief rebuttal.
Yes, my friend already had spoken about. 1 second. Yeah, and there are certain technical difficulties in this case also. The thing is, there may be acute turn, and we don't know where is the opening, and there is chance of scope breakage, and it will be cost. And if you take care of this one, consider cost-effective thing. PCNL will be far cost-effective for the patient with a low complication rate if you use MINI-PCNL. And the thing is, abnormal anatomy into diverticulum may cause damage to the scope, and blind incision over the urothelium may cause bleeding from the infranibullar vessels. And if bleeding starts, we have to abandon the procedure. There is no other go. And in PCNL, we can give complete clearance for the patient, even in this patient, and it's a single procedure. And we can give a better symptom-free rate for the patient. Whereas in RIRS, as quoted by Campbell and AUA, the symptom-free rate is very less. And the diverticular ablation is very less with RIRS compared to the PCNL as given in AUA guidelines. And if calculus cannot be cleared in RIRS if opening is not identified. Yeah, thank you, sir.
Thank you, Ravi Teja. Now we can stop sharing. So we have come to the end of the debate, and we'll move on to the next session. So thank you all speakers for excellent talk and intense debating. Now we move on to our final session, which is a session known as Listen from the Innovators, where we have senior faculty members speak on various innovations which you have done. Meanwhile, this time, when the last session will be going on, our other senior faculty judges will be scoring your debate. So the first talk is by Dr. Mahesh Desai sir, who is a very well-known person in the field of urology, both in India and globally. He is the medical director of Mujibhai Patel Urology Hospital, Nadia, and has various publications, awards, and innovations in the field of endourology. He was also the past president of Urology Society of India, World Endourology Society, and SIU. Professor Desai will be giving a lecture on innovation of MicroPerk and how the idea of MicroPerk occurred to him. So can we have the presentation of Dr. Mahesh Desai, sir?
Greeting from Nadia. Stone management has drastically undergone a change since 1980 with development of minimal invasive surgery, ESWL, PCNL, and urotoscopy. In somewhat, there was an era of ESWL first, followed by improvement in the urotoscopy, and then the PCNL was always there. And then that the way the stone was managed. But one of the main problem was the residual stone. It was very difficult to have 100% clearance in all the patient. That 100% clearance varied between say 60 to 70% in ESWL, 80% in flexible urotoscopy, and probably 80 to 90% in PCNL. And still a awkward small stone left behind. And that was a problem because that became a nidus for another stone formation. So those small stone previously we tried to deal with ESWL. So combination with PCNL and ESWL, or ESWL multiple sittings, or you do urotoscopy and the residual stone can be do the second sitting or ESWL. But what we thought at that time, sometimes the stone is in a very awkward position. It doesn't get cleared so easily, especially in the lower callexal residual stone or any residual stone in any calyx. But so I thought that if we can puncture that calyx containing the residual stone, then, and if with the presence of laser, we can break the stone and with flush it out, probably would have a significant clearance of the stone. That's why I developed this MicroPerk. And here you can see that the needle is very small, and it's a 14 gauge needle. And then you have a telescope, which is 0.9 millimeter. Let me take it out. And this is a telescope, 0.9 millimeter, which is a flexible, and then you can use, and then you can, once you are inside, you can use a three-way where you can pass a irrigation, a telescope, and laser fiber, and then you can break the stone. So idea of having a MicroPerk was primarily to tackle the residual stone. But with the success of breaking the stone, then say, why not use it for a small stone? Say 1 centimeter stone. So in that case, we use a cannula, and then we could drain it. We could suck it out, the gravel. Like say this is the cannula where you can pass into the system, and then you can use a MicroPerk with the suction, and you can, whatever is broken is sucked out. And similarly, this is the one which is of quite flexible, and you can use it, and then you can suck out small fragment. Especially in children, where the collecting system is quite compact, we could use the MicroPerk to break the stone. If usually stones are small, 1 centimeter or maybe 2 centimeter. I have done a 2 centimeter in children in a pelvic stone and through the MicroPerk. And these stones are soft. They just go into a dust and they clear it up. So MicroPerk basically was developed as an adjuvant to any of the energy like ESWL, PCNL or urotoscopy, and to deal with the residual stone. And children, you can use it as a primary.
Thank you, Mahesh Desai, sir, for inspirational talk on MicroPerk. So the next speaker in the session of Innovate, Listen from the Innovators is Dr. Janak Desai, sir. Professor Janak Desai is one of the senior urologists from India whose areas of interest include stone disease and uro-oncology. He is the director of Samved Hospital, and also he was the founder president of Gujarat Urology Association. He has given various talks and conducted various live workshops, and sir is quite famous for inventing the ultra mini PCNL, and he is going to speak on the idea of having ultra mini PCNL as an armamentarium for renal stones. Can we have the presentation of Dr. Janak Desai, sir?
Thank you, Arvind, for asking me to speak about how I developed Ultra Mini PCNL. Essentially, two observations. When we were doing those PCNLs, we realized that when we were doing the initial Teflon dilation, the bleeding was minuscule. But the moment we switched to the larger dilation, sometimes there was bleeding that we saw when we pulled out Amplat's dilator to be exchanged for the next. So we realized that if the dilation is restricted, the bleeding is less. So that was the first observation, which we could prove on our nephrectomy specimens. Back then we did nephrectomies, partial nephrectomy concept had not picked up, and therefore we tried it on those specimens immediately by trying out those dilation, and there was a lateral tear which you can see in this picture. Okay, so that was one observation. The second observation was that of a whirlpool. That when you see a whirlpool, it pulls those small objects into the center and throws it in the center. In my case, we created this whirlpool and the stone fragments were engaged and it would pull the fragments and bring them out. So these were the two original concepts in my mind. And a chance meeting with Mr. Werner Scholli, the owner of the company, who was visiting India once, and he showed me a mammary ductoscope, a very thin telescope which was used as a mammary ductoscope in China. And I told him, can you make it a little stronger, maybe a little thicker? 1 millimeter is what he finally produced, and this is the telescope. He gave it to me, the initial version of the telescope. Finally, we had to think about the initial prototypes, which I made it in India, a single small tube on which we stuck a pediatric catheter to create that whirlpool, which was later on made a little, it was refined a bit, and we welded a small thin tube in India. Of course, the quality was a little rough, the welding was not too good, and we made some videos and sent it to Mr. Werner Scholli. They, in their R&D department, they thought that this was a project worth pursuing, and he came up with the final version of UMP, of course with a few prototypes, and each time a prototype was being given, it was printed not for human use. So we made several such prototypes, and finally the final version, in which this is the UMP sheath with a side tube which will create that whirlpool by injecting saline, and everything is pulled out. And CE certification was obtained, subsequently FDA approval was obtained, and and now it is already marketed in the United States by Wolf, because Surely will not market themselves. It's an OEM company. So Surely does not market, and therefore we are here with the final version, a 11 French sheet which is yellow coded, a 13 French sheet which is green coded, and a longer version for those obese patients in which this sheath is long, which is good enough for the obese patient. So these are the 3 sheets that would come in a standard set, and the rest is been shown in several workshops across the world. We have done workshops now in almost 35 countries across the world, and a chapter in the Smith's textbook of urology, and we have our publications in the British Journal, in the Journal of Urology, and the World Journal of Urology. So thank you once again. Miniaturized PCNL is something which came from India. 22 until the micro PCNL, all those concepts are Indian concepts which are being now pursued by a lot of urologists across the world, and that gives us a lot of happiness. So thank you once again.
Thank you, Janak Desai sir, for a very descriptive and detailed talk on the invention of Ultra Mini PCNL. Now we move on to the next talk. Our next speaker is Dr. Kaushik Shah. He is a senior consultant from Gujarat who has invented the SuperPerk, which is used for renal calculus. He has various innovations and awards, and here he will be discussing about the idea and invention of SuperPerk, which occurred to him. Can we have the presentation of Dr. Kaushik Shah, please?
Dear friends, good evening. I am thankful to the Urological Society of India and Indian School of Urology for inviting me for this talk. The SuperPerk is a continuously evolving technique. It started with alkene cannula, later 10 French sheet size, then 12 and 16 French sheet size, and expanded to all TRACT sizes. The idea of SuperPerk came during this conference. The MicroPerk and UMP were the talk of the town in that workshop. They being costly gadgets, it was difficult for most people to replicate the results. On way home, I thought of how to go ahead with this technique. At home, I realized that alkene cannula is a 9 French through which my Wolf 4.5 French ureteroscope goes easily. I have a laser, I'm good at RIRS. So in the case of doing PCNL, after putting alkene cannula, I inserted my ureteroscope via cannula, saw the stone, and started fragmenting the stone with a laser. I gave a wash via ureteric catheter to remove the fragments, and all the fragments were coming out easily through this. I tried to duplicate the results by using the same technique in number of cases. The results were fantastic. The advantage which I got while attempting this technique was that I had not to buy any new equipments. The track size was almost the same. I was able to use 0.8 mm pneumatic probe, biprong and triprong forceps. I can go in all calyces, even in upper ureter, and the stones were removed on table. I presented my work in SIU program with the blessings of Mahesh Bhai, and I named the technique as SuperPerk. However, the biggest challenge was a fragment removal. I wanted to add a suction, so after brainstorming, I came up with an idea of suction outside the nephroscope and retrograde irrigation via multi-hole ureteric catheter, and 10 French sheet size assembly with a suction master was added in armamentarium. With the success of this procedure, I was invited by Dr. Mahesh Bhai and MPH team to demonstrate live at Doha, Qatar, and in an annual conference of American Urological Association. I was pleased, honored, and mesmerized. However, the journey was ongoing. I wanted a company to produce quality products and a platform for ongoing research and development. So Usha Enterprise was started. It came out with a number of products under my guidance. 12 French, 15, 18, 21 and 24 French sheets were made as per the request of number of urologists so that they can do all sizes of stone with whatever they have. Suction machine with a low power and a bottle with a tap and a stone catcher bottle was also developed to sort out the problems of using suction while doing this procedure. So this whole system develops something like this. Multi-hole ureteric catheter is inserted in the upper tract. The sheath is inserted. The suction is controlled by the air opening and the suction tube attached to it. You can use any nephroscope. You can use laser. You can use pneumatic, and the whole procedures can be completed. After getting this success, now our aim is to refine further this product and to solve the other problems in PCNL like puncture technique and different nephroscopes and so on and so forth. Thank you.
Thank you, Dr. Kaushik Shah. So now we come to the conclusion of this exciting second round of endourology crossfire debate. So meanwhile, the scoring of the debate was done by senior endourologists and it was tabulated. All the debaters were excellent, but as you all know, we have to announce only 3 winners. And we have 3 winners in the first debate, which was on ESWL versus PCNL for pediatric renal stone disease. We have Dr. Rohit Ranjan. And for the second debate, which was on prone versus supine PCNL for a pelvic calculus, Dr. Abhish Hegde is a winner. And for the third debate, which was on RIRS versus PCNL for caliceal diverticular stone, we have Dr. Sepuri Raviteja as the winner. Congratulations to all the winners and all the participants who have taken part and put in all their effort for this debate. And meanwhile, we also thank all the speakers who have given their lectures and the technical team of IPCA who have been wonderful and helping us conduct this second round of debate. And I'm also thankful to my colleague, Dr. Karthikeyan, who has given all the support and who has moderated this session with me. And before we conclude, I would like to invite you all for the third and the final round of this wonderful debate in endourology, which is called Endourology Crossfires. And this will be held on 23rd December, Wednesday, which is exactly 1 week from now. And we will be soon sharing the link for viewers, and the exact timings of the debate will be announced through email and even through various social media accounts. Thank you all. And thanks for joining us today in this wonderful debate. And we look forward for more number of people attending the final round, which is on 23rd December. Thank you.
Thank you, Dr. Sishan. Thank you.